So imagine trying to fix a leaky kitchen faucet by just deliberately flooding your entire house.
Right, which sounds completely crazy.
Yeah, totally crazy.
Yeah,
But for decades, I mean, that was kind of the prevailing approach to treating menopausal symptoms.
it really was.
You had these localized problems, but the solution was often just this biological sledgehammer, like flooding the entire body with systemic hormones.
Right, the master key approach.
Exactly. But today for our deep dive, we're looking at a completely different philosophy, like a pharmacological smart key that basically bypasses the rest of the house to fix just the faucet.
And it is a profound shift in how we approach hormonal decline. I mean, we are finally moving away from blunt instruments
Mhm.
and toward these highly targeted, tissue-specific solutions.
Right. And the specific issue we are targeting today is one that, well, it affects millions of women, but it is rarely talked about openly.
Yeah, the stigma is huge.
It is. We hear constantly about the hot flashes, the mood swings, the night sweats.
The classic symptoms everyone knows.
Right. But the clinical guidelines and FDA data we are diving into today, they focus on a symptom that drastically alters a woman's quality of life. Postmenopausal vaginal dryness and painful sex.
Which is clinically known as dyspareunia.
Dyspareunia, right. And if you are navigating menopause or, if you know someone who is, you know that the stigma around this keeps people suffering in silence.
And the silence is honestly the most damaging part.
Yeah.
Because we are talking about a condition that, well, it doesn't just cause physical discomfort.
No, it disrupts intimacy.
Exactly. It impacts relationships, and it just fundamentally changes how a woman moves through her daily life. So pulling this out of the shadows is step one.
And step two is understanding that the science has actually evolved to meet this need.
It really has.
So our mission for this deep dive is to unpack this really innovative oral treatment called ospemifene. You might know it by the brand names Osphena or Sensio. And the central biological puzzle we want to solve for you today is this. How does swallowing a daily pill effectively treat a highly localized vaginal symptom without, exposing the entire body to estrogen?
Right, reversing that severe dryness and pain, but specifically without the systemic estrogen.
Exactly. But to get there, we really have to look at the cellular machinery first. Because a drug like this, it doesn't make sense until you understand the sheer architectural collapse that happens to this tissue when estrogen disappears.
And that architectural collapse really is the root of the problem.
Yeah.
You see, when menopause begins, systemic estrogen levels plummet.
Right.
And most people associate estrogen purely with reproduction, the uterus, the ovaries. But estrogen receptors are heavily concentrated throughout the entire pelvic region.
Oh, really? Everywhere?
Everywhere. They line the vagina, the urethra, the base of the bladder, and even the surrounding pelvic floor muscles.
Wow, so they are essentially the structural foundation for that whole biological neighborhood.
They absolutely are. Those receptors rely on a constant, steady stream of estrogen to maintain the integrity of the tissue.
Okay, so when that stream dries up?
The body develops what we call genitourinary syndrome of menopause, or GSM.
GSM. Oh.
Okay, yeah. And the most physically disruptive component of GSM is vulvar and vaginal atrophy.
And atrophy is just such a brutal medical term.
It is.
It always brings to mind, like, muscles wasting away after being in a cast or something.
Well, clinically, that imagery is pretty appropriate.
Mhm.
Without estrogen to signal cell growth and repair, the vaginal epithelium, which is the protective lining, literally thins out.
So it just shrinks.
Basically, if you look under a microscope, you see a dramatic loss of superficial epithelial cells.
And those are
Those are the plump, mature cells that provide a barrier. So as those vanish, the tissue loses its collagen and its elastin.
the stretchiness.
Right. A healthy vagina has these folds called rugae that allow the tissue to stretch and expand comfortably. But with atrophy, those rugae flatten out and disappear entirely.
When I was going through the clinical descriptions of this in our sources, the best visual I could come up with was a sponge.
Okay, a sponge.
Yeah, think of healthy vaginal tissue as a damp kitchen sponge. It's flexible, it's resilient, you can squeeze it, and it immediately bounces back to its original shape.
Sure.
But when you remove the estrogen, it's like taking that same sponge and just, leaving it out on a hot driveway in the glaring sun for a week.
It completely loses its mechanical properties.
Exactly. It becomes brittle, it becomes stiff, and if you try to bend that sun-baked sponge or, apply any friction to it, it doesn't flex. It tears and flakes apart.
Which is exactly what happens to the tissue. It becomes what doctors call friable.
Friable.
Yeah, meaning it is highly prone to microscopic tearing and bleeding. particularly during the friction of sexual intercourse.
And that structural failure is the primary driver of dyspareunia, right? The intense pain.
Absolutely. The sponge analogy captures the mechanical failure perfectly. But the lack of estrogen also causes a chemical failure.
Oh, right. The ecosystem.
Yes. It alters the local ecosystem. The vaginal pH, which should naturally be acidic, actually spikes up over 5.0. It becomes much more alkaline.
Which I imagine opens the door for a whole cascade of other issues, right? Because that acidity is there for a reason.
That acidity is the primary defense mechanism. It's maintained by healthy bacteria called lactobacilli, and they thrive in an estrogen-rich environment.
Okay, so when the estrogen drops and the pH rises...
The lactobacilli just die off.
Wow.
Yeah, so not only is the tissue physically brittle, but its chemical shield is gone, which leads directly to the chronic irritation and those recurrent urinary tract infections that so many postmenopausal women experience.
So the biological environment is essentially a desert. Now, if you are listening to this and you followed the logic so far, you're probably thinking, well, if the vagina is missing estrogen, just put estrogen directly into the vagina.
Right, which makes logical sense.
And historically, that has been the gold standard. I mean, we have estrogen creams, little dissolvable inserts, silicone rings.
All localized options, yes.
So why didn't we just stop there? Like, why go through the massive expense and clinical trials to invent a pill that you swallow for a localized vaginal problem?
Well, the clinical reality is that localized treatments, while they are highly effective in theory, they often fail in practice.
Wow.
The physical barriers are significant. Imagine a woman who has severe arthritis in her hands.
Oh, right.
The fine motor skills required to maneuver a specialized applicator or to unwrap and insert a tiny vaginal tablet, I mean, that might be completely out of reach for her.
And our sources also touched on the pain aspect, which honestly feels like a terrible catch-22. We just established that this tissue is incredibly thin, dry, and prone to tearing.
It is a cruel paradox, really, for women with severe atrophy or those dealing with conditions like vaginismus.
Spasming, right.
Yes, the involuntary spasming of the pelvic floor muscles. For them, trying to insert a plastic applicator or a cream can be excruciating.
Just blinding pain.
Exactly.
Mm-hmm.
And if the prescribed treatment causes immediate sharp pain, patient compliance drops to 0. A woman simply won't use it.
Which is completely understandable. Add in the fact that creams can be messy or, that some women just have a strong personal preference against using localized products.
Right.
You suddenly have millions of women with a massive unmet medical need. They need systemic oral relief, but they do not want the risks associated with flooding their entire body with estrogen.
Which brings us to the molecular ingenuity of ospemifene.
Let's talk about the pill.
So it's a 60-milligram oral tablet taken once a day. But the most vital piece of information on the FDA label is that ospemifene is not a hormone.
It is not estrogen.
It is not estrogen.
Yeah.
It belongs to a specialized class of therapeutics called SERMs, S-E-R-M, selective estrogen receptor modulators.
Selective estrogen receptor modulators. That word selective is the hinge this whole deep dive swings on, I think.
It really is.
Let's build on that leaky faucet and smart key concept from earlier to visualize how a molecule can actually be selective.
I like this analogy.
Okay, think of the estrogen receptors in your body as a series of physical locks on different doors.
Yeah.
You've got a lock on the front door, which represents the vagina.
Right.
You have a lock on the bedroom door, representing breast tissue, and a lock on the kitchen, which is the uterus.
So a standard systemic estrogen pill is a master key. You swallow it, it circulates, and it seamlessly unlocks every single door.
Just floods the whole house.
It activates the receptors everywhere simultaneously.
But a SERM, like ospemifene, is engineered to be a programmed smart key. It circulates through the blood and arrives at the front door, the vagina.
Okay.
It fits perfectly into the lock, turns it, and lets all the restorative healing effects in.
Exactly.
But then that same molecule floats up to the bedroom door, the breast tissue. And because of the subtle differences in how the receptors in the breast are folded, the smart key slides into the lock, but it jams.
It can't turn.
It can't turn. In fact, it gets stuck in the keyhole, completely blocking any natural estrogen from getting inside.
That is a perfect visualization. In pharmacology, we refer to the key turning the lock as an agonist effect.
Agonist, okay.
Yeah. Ospemifene acts as an agonist in the vaginal tissue. It binds to the receptor, mimics estrogen, and signals the tissue to start rebuilding.
Oh, wow.
It tells the body to produce glycogen, to thicken the lining, and to generate those protective superficial cells.
So it essentially rehydrates the dry sponge.
It does.
Yeah.
And as a collateral benefit, it also acts as an agonist on bone tissue. helping to maintain bone density.
Oh, that's a nice bonus.
Right. But in the breast tissue, where the key jams, it acts as an antagonist. It actively blocks estrogenic activity.
Fascinating.
Then, in the uterus, the endometrium, it has a weak partial effect. It turns the lock just a tiny bit, which we have to monitor carefully, but it doesn't throw the door wide open.
I mean, the elegance of that drug design is stunning. You are getting targeted, localized relief simply by swallowing a pill. But as someone looking at a stack of clinical trials, my next question is, does the smart key actually work in human beings or just in a petri dish?
Well, the clinical evidence behind the FDA approval is extensive. The pivotal data came from multiple large, 12-week, randomized, double-blind, placebo-controlled trials.
The gold standard.
Exactly. And the researchers demanded both objective, physical proof, and subjective, symptom-based proof.
Well, let's look at the physical proof first. How did the tissue actually change?
The microscopic changes were undeniable. After 12 weeks on ospemifene, vaginal smears showed a statistically significant drop in parabyssal cells.
And those are the...
Those are the deep, immature cells that only get exposed when the protective barrier is worn away.
Okay, got it.
Simultaneously, there was a massive increase in the superficial cells. The healthy, plump surface cells returned.
So it isn't just like masking the pain. It is physically rebuilding the structural wall of the vagina.
Rebuilding the wall and resetting the chemical environment.
Right, the pH.
Yeah, the trials showed a significant lowering of the vaginal pH back toward that healthy acidic state. The lactobacilli can return, the risk of infection drops, and the physical resilience of the tissue is restored.
Okay, but I'm going to push back on the data here for a second.
Go for it.
Because the subjective side of the trials, like how the women actually felt, it has a really interesting quirk in the methodology.
Ah, the lubricant.
Yes. The sources state that all the patients in these 12-week trials, both the ones taking ospemifene and the ones taking the placebo pill, they were handed a non-hormonal vaginal lubricant and told to use it as needed.
That is correct.
If I'm a skeptic, I look at that and think, well, how do we know the drug did anything? Like maybe the lubricant is what stopped the pain and the pill is just getting the credit.
And that is a totally fair question, but it's actually the beauty of a well-designed placebo-controlled trial.
How so?
The lubricant was a baseline variable for everyone. The women in the placebo group did experience some mild symptom relief because, as you noted, they were using a high-quality lubricant. But the researchers aren't just looking for improvement. They are looking for the delta, the statistical difference between the two groups.
Ah, so you subtract the benefit of the lubricant to see what the drug actually accomplished.
Precisely. And the women taking ospemifene reported a vastly superior, statistically significant reduction in the severity of their most bothersome symptoms.
Which were the dyspareunia and dryness?
Specifically those, yes. The lubricant provided a temporary superficial slip. The pill was driving deep cellular reconstruction that fundamentally ended the pain.
Wow.
And the data shows this relief begins as early as 4 weeks into treatment, reaching maximum efficacy around the 12-week mark.
Okay, the delta proves the drug works. That makes sense. But there is a very specific, almost bizarre rule about how this pill must be taken for it to actually absorb into the body, right?
Yes, the pharmacokinetics of ospemifene are heavily dependent on food. This is not a drug you can take on an empty stomach with a quick glass of water in the morning.
Okay.
It is highly lipophilic.
Meaning it loves fat.
Right. It requires fat to be effectively carried across the intestinal wall and into the bloodstream.
So how much food are we talking about?
Well, the clinical guidelines are remarkably specific here. Taking ospemifene with a high-fat, high-calorie meal, the studies actually pegged it at an 860 kilocalorie meal.
860 calories, wow.
Yes. Taking it with a meal like that increases the absorption of the drug into the blood by 2 to 3 times compared to taking it while fasting.
2 to 3 times the absorption just based on what you ate with it. So if you take it on an empty stomach, you are basically flushing the medication and the symptom relief down the drain.
You won't achieve the necessary blood concentrations to turn those cellular locks. You really need to tie this medication to your most substantial meal of the day.
Whether that is a hearty breakfast or dinner.
Exactly.
That is a critical takeaway if you are listening to this and considering this therapy. It has to be built into a real meal routine.
It really does.
So we have an oral pill taken with food that operates as a smart key to rebuild the vaginal wall while intentionally avoiding the breast tissue. I mean, it sounds like an absolute triumph of modern medicine.
It is very impressive.
But we know there is no such thing as a free lunch in pharmacology. A systemic drug, even a selective one, is circulating everywhere. What kind of collateral damage are we looking at?
Well, because it operates systemically, there is a footprint. And we have to start with the most common side effect, which highlights the complexity of manipulating hormones.
And looking at this side effect profile, there is a deep, almost cruel pharmacological irony here.
Yes, there is.
The number one side effect of this drug, which is designed to treat a menopausal symptom, is hot flashes.
It sounds absurd, but it makes perfect sense when you look at the brain.
Really?
Yeah, roughly 7.5% of users experience hot flashes. Remember, ospemifene is modulating estrogen receptors all over the body.
Okay.
In the hypothalamus, which is the brain's thermoregulatory center, the drug can sometimes act as an antagonist.
It blocks it.
It blocks the receptors, tricking the brain into thinking estrogen levels have suddenly dropped even further.
Oh, wow.
So the brain panics, tries to cool the body down, and triggers a hot flash.
So the smart key jams the lock in the brain, too.
In some women, yes. Now, the guidelines note these flashes are usually mild to moderate and transient, but a patient needs to know that going in.
Sure.
However, hot flashes are an annoyance. We need to talk about the FDA boxed warnings, which are the most severe safety warnings issued for a medication.
Right. And ospemifene carries warnings for endometrial cancer and cardiovascular disorders.
Yes.
Let's tackle the uterus first. We established earlier that this drug has a weak partial effect on the endometrial lock. It turns it just a little bit. What does it actually mean for the patient's cancer risk?
So because it is a weak agonist, it gently stimulates the lining of the uterus. In the 12-month clinical trials, they observed a mean increase in endometrial thickness of just 0.8 millimeters.
I mean, 0.8 millimeters is practically microscopic.
Clinically, it is considered insignificant. The risk of developing endometrial hyperplasia, which is an abnormal overgrowth of cells that can precede cancer, was extremely low, just 0.3% in the trials.
It's very low.
And there were 0 cases of actual endometrial cancer reported during the 52-week safety studies. But because the stimulation exists, the FDA mandates the boxed warning.
So how do you manage that practically?
Extreme vigilance. Any unexpected or undiagnosed vaginal bleeding while taking this drug must be immediately investigated by a doctor to rule out malignancy.
That makes sense.
Furthermore, if a woman still has an intact uterus, many physicians will strongly consider prescribing a progestin alongside the ospemifene.
As a counterbalance.
Exactly. Progestin acts as a counterbalance, protecting the uterine lining from that unchecked estrogenic stimulation.
It's an extra layer of armor. Okay, the second half of that boxed warning covers cardiovascular disorders, specifically deep vein thrombosis, or DVTs, which are blood clots in the legs, and strokes.
Right. And this is an inherent risk associated with the entire SERM class of medications.
Even other ones?
Yes, including well-known breast cancer drugs like tamoxifen. Modulating estrogen receptors in the liver slightly alters the production of certain coagulation factors in the blood.
Okay, so it changes how the blood clots.
Exactly. In the ospemifene trials, the rate of DVT was 3.65 cases per 1,000 patient years.
Which is quite low, but obviously not zero.
It was statistically comparable to the placebo group in the trials, actually. But because it is a known class effect, the warning is absolute.
So who shouldn't take this?
This drug is strictly contraindicated for anyone with an active DVT or a history of arterial thromboembolic disease, like a past stroke or a heart attack.
And the sources also highlight a very specific surgical warning regarding blood clots.
Yes, because immobility increases the risk of blood pooling and clotting. If you are scheduled for a major surgery or, if you're going to be put on strict bed rest for any reason, you must completely discontinue ospemifene 4 to 6 weeks beforehand.
Okay. If you are a patient sitting in a doctor's office, balancing everything we've just discussed, you might hear the phrase boxed warning for cancer and strokes, and your immediate instinct might be to just walk out the door.
Natural.
How does a physician sit across from a patient and navigate that step therapy debate? Like, how do you justify prescribing a drug with these severe warnings for a condition like vaginal dryness?
Well, you justify it by understanding how debilitating severe vaginal atrophy actually is.
It's a quality of life thing.
Entirely. It is crucial to emphasize that ospemifene is not a first-line drug for a woman who feels a mild twinge of dryness once a month.
Right.
The clinical guidelines are explicit. This is reserved for women whose symptoms are moderate to severe, women who've tried the over-the-counter moisturizers and failed.
Or the ones with arthritis, like we mentioned.
Yes, women who cannot physically tolerate the pain of local vaginal creams or whose dexterity prevents them from using them.
You're talking about women whose daily lives are fundamentally compromised, where intimacy is impossible. And, Even just sitting in a chair for an hour causes burning pain.
Exactly that demographic.
Yeah.
For those women, the profound benefits of restoring their sexual health, their relational intimacy, and their baseline physical comfort vastly outweigh a 0.3% risk of hyperplasia or a 3 in 1,000 risk of a blood clot.
Assuming they are screened properly.
Provided the doctor has properly screened their cardiovascular history, yes.
Sure.
It is a calculated, deeply personal quality of life decision.
Which brings me to a fascinating nuance in the guidelines regarding breast cancer survivors.
Ah, yes.
We know systemic estrogen is generally forbidden for women who have had estrogen-positive breast cancer, but we established that ospemifene acts as an antagonist. It aggressively blocks the estrogen receptors in the breast.
Right, the key jams in the lock.
Exactly. So does that mean this drug is a loophole for them?
It is a vital, though carefully managed, lifeline. Ospemifene has not been formally studied during active breast cancer treatment. So if a woman is actively battling known or suspected estrogen-dependent cancer, this drug is contraindicated. However,
There is a however.
there is. The American College of Obstetricians and Gynecologists notes it is the only oral therapeutic option approved for use in women with severe VVA after they have fully completed all of their breast cancer treatments, including their adjuvant endocrine therapies.
That is massive
Yeah.
because those adjuvant therapies often plunge women into aggressive, medically induced menopause, right?
Mhm.
Leaving them with incredibly severe atrophy and almost zero treatment options.
And because ospemifene blocks the breast receptors rather than stimulating them, it provides a safe avenue to relieve that severe localized pain without re-triggering the breast tissue.
Let's pull all of this together to see the big picture. Ospemifene represents a brilliant pharmacological workaround for postmenopausal women suffering from severe vaginal dryness and dyspareunia.
It really does.
By operating as a selective estrogen receptor modulator, it acts as a molecular smart key. It navigates through the bloodstream, physically rebuilds the vaginal wall, and restores the acidic ecosystem, all while intentionally locking out the breast tissue.
Terrific summary.
It requires the patient to take it with a substantial, high-fat meal to absorb properly, and it demands careful cardiovascular and uterine screening. But for women who cannot utilize localized creams, it offers a systemic cure for a localized collapse.
It's a triumph of targeted engineering. And looking at the mechanics of this SERM leaves me with a provocative thought about how we view human aging.
Oh, how so?
Well, for so long, we viewed aging and hormonal decline as a massive systemic failure. Blank void that needed to be aggressively refilled with broad-spectrum hormones.
Flooding the whole house to fix the faucet.
Exactly. But the ingenuity of the smart key proves that the body's locks are incredibly nuanced. What if the future of treating age-related decline, whether we're talking about tissue atrophy, bone density loss, or even cognitive changes, isn't about blunt replacement therapy?
What if we don't need the master key at all?
Right. What if the next frontier of medicine is designing thousands of these highly specific molecular keys? Drugs capable of turning localized cellular machinery on and off exactly where it hurts, without disrupting the delicate balance of the rest of the biological house.
A completely bespoke, localized approach to the biology of aging. I mean, that is a brilliant concept to leave on. We hope this deep dive gave you a clearer understanding of the profound mechanics behind this medication and the true clinical reality of treating GSM. Thank you for joining us for this conversation, and as always, keep exploring the science of your own health.